If you're reviewing home program adherence between visits, adjusting exercises based on patient-reported pain scores, or sending a check-in message before someone's next appointment, that is clinical work. RTM pays for it, and it's time for your clinic to capture that revenue. And in 2026, CMS changed the code structure in ways that affect whether your clinic is actually capturing that revenue or leaving it on the table. Remote Therapeutic Monitoring is a CMS reimbursement program for care that happens outside of in-person visits. Here's what makes it different from RPM, Remote Patient Monitoring. RPM requires a physician order. RTM does not. PTs, OTs, and SLPs can enroll patients directly, without a referral from a physician. The patient uses an FDA-recognized app or device to log pain, adherence, functional status, or activity data. Your clinical staff monitors that data, communicates with the patient at least once per month in real time, and documents the time spent. That is exactly what gets billed for the work you do. Before 2026, 2 billing cliffs were cutting clinics out of reimbursement, even when the clinical work was done. Cliff 1. The 20-minute management floor. The primary management code, 98980, requires at least 20 minutes of clinical time. Patients enrolled mid-month almost never hit that threshold. CMS addressed this with new code 98979, which covers the first 10 minutes of management. Mid-month enrollments are now billable. Cliff 2. The 30-day device supply requirement. The existing device supply codes, 98976 for musculoskeletal and 98977 for respiratory, required 30 or more days of patient data. Patients with fewer than 16 app engagement days got 0 device supply reimbursement. CMS added 2 new codes to fix this. 98985 for MSK monitoring covering 2 to 15 days and 98984 for respiratory covering the same range. The result, far fewer patients fall through the billing window, and clinics get paid for the work they were already doing. Take a look at these updated codes for your clinic's billing guide. This is the part most clinics underestimate. CMS expects 4 things documented per billing period. 1. Patient consent for RTM, documented before you enroll them. 2. The device or app used and confirmation it meets FDA recognition requirements. 3. The real-time interaction, the date, the method, and what was clinically addressed. 4. Total time spent reviewing data and managing the plan of care, logged during the period, not estimated at month end. Time documentation is where audits start. Log it as you go. SPRY is built for outpatient rehab. RTM tracking, documentation, and billing, including all the 2026 codes, are built into the platform. Check out our full guide at spript.com. Subscribe for billing and clinical operations content built for U.S. rehab clinics. RTM questions. Drop them in the comments. We read them.